So the next case is going to be presented by Dr. Deemer. He's going to present on imaging and planning for the complicated strabismus or reoperations.
I continue to have no commercial or financial conflicts of interest. Incidentally, this particular animal was a renegade bull who was driven from the herd because of his misbehavior and had been known to attack Humvees. Okay, this is a case of a 63-year-old woman referred to me with a 9-month history of vertical binocular diplopia, particularly when looking up, since she had undergone iodine-125 brachytherapy for a choroidal malignant melanoma in her right eye. According to the operative report, this required extirpation and hangback of the right superior rectus muscle. Now you can see, looking in extreme down gaze, she could just barely fuse, and in order to enjoy fusion, she went around with an extremely uncomfortable chin elevation. But when she looked straight ahead, or especially looked up, there was this notable right hypotropia that you can see in the middle center. This is her Hess screen test. It shows a marked right hypotropia, a secondary deviation with a marked over-elevation of the left eye in upward gaze, and improved vertical binocular misalignment when she looked down. So we have to consider what sort of implications this brachytherapy might have for our strabismus repair operation. Dr. Alfredi, along with Dr. Pinellas and Dr. Velez, have reported that in this situation there may be muscle enlargement, weakness, and especially adjacent fibrosis when iodine-125 plaques have been applied. And I have noted that in irradiated orbit, sometimes rather severe necrosis or friability may be induced in an extraocular muscle exposed to radiation directly, although in this setting, a gold shield is designed to prevent direct irradiation of the extraocular muscle if everything goes well. So let's consider what sort of things imaging can show, because as pediatric ophthalmologists who do strabismus, we are not like neuro-ophthalmologists who automatically image everybody. Only selectively would even an advocate image. Now, MRI can distinguish or reveal some complex alternate pathologies. Atrophy, inflammation, avascularity can all be readily demonstrated by orbital imaging, particularly MRI. Hypertrophy, as you all know, is the hallmark of thyroid ophthalmopathy. We can demonstrate abnormal contractility of extraocular muscles, as in those that are either paralyzed or misinnervated, as in a congenital cranial disinnervation disorder. And we can disclose the damage done by an endoscopic entry or a partial excision through surgical accident or some sort of complicated trauma. And finally, we can demonstrate gross muscle displacements as might occur with the heavy eye phenomenon or with the sagging eye syndrome. So here is an example of a couple of things that can be shown by good quality surface coil MRI imaging. You see in the left orbit atrophy of that superior rectus muscle, particularly evident anteriorly in the orbit, in this case of idiopathic superior rectus atrophy. Here's an example of demonstration of muscle contractility. So we see here that the superior rectus muscle will demonstrate a larger cross-sectional area when the muscle is contracting in upward gaze, yet a smaller cross-sectional area when the muscle is relaxing in downward gaze. Conversely, the superior oblique muscle will exhibit a smaller cross-section in upward gaze and a larger cross-section in downward gaze. And these findings indicate that the muscle is innervated and it is functioning normally, at least from a contractile standpoint, but it does not prove that the muscle is applying force to the eye. In settings of the acute rupture of the LR-SR ligament, one can get an acute incomitant hypotropia, as demonstrated here in this elderly individual whose lateral rectus muscle suddenly slipped below the equator of the globe due to rupture of that ligament. That kind of pathology is plausible in this setting due to the trauma in the orbit associated with implantation of the radiation plaque. So get back to what we found here. This is T1-weighted gadolinium-enhanced imaging showing on your left and on your right the presence of that melanoma. So now we know where it is, just posterior to the equator. The superior rectus, however, appears to end at about that same position. The superior rectus is contractile in this case because we see that it increases its cross-section in upward gaze and decreases it in downward gaze. But high-resolution T2 coronal imaging demonstrates presence of the superior rectus muscle throughout the entire upper row, which is ordered from posterior to anterior. But the superior oblique tendon is the most anterior point at which we can identify the superior rectus. So maybe there's some relationship between the two. Knowing that there was no radiation necrosis, we were able to approach the strabismus surgery confidently. We expected the disinserted right superior rectus, and it was indeed adherent to the posterior aspect of the reflected superior oblique tendon with a lot of scarring, but I was surprised to find that the superior rectus muscle was split longitudinally. The superior rectus was reattached, and the repair was made of its split, and the release from the incarceration of the superior oblique tendon was performed. The postoperative result was improved, although there was some modestly limited superduction. To conclude, MRI can reveal complex alternative pathologies, including atrophy, inflammation, avascularity, hypertrophy, contractility abnormalities, gross muscle damage, and displacement, but it cannot demonstrate scarring in or near the insertion or the exact location of an insertion or the path of the reflected superior oblique tendon. And by the way, of course, irradiated extraocular muscles may be friable and disintegrate on manipulation, so that piece of information can be crucial. Thank you.